Hello, my name is Dr. Michael Hawks. I'm from the Division of Pediatric Infectious Diseases, and I'm talking today about vaccination, their impact, principles, and examples. Just a note of introduction that vaccines are often a hot topic in the news, as now when influenza is top priority. Just recently, January 6th, H1N1 influenza is in prime season in Alberta, and the Minister of Health, James Talbot here, Chief Medical Officer of Health, rather, James Talbot here is encouraging everyone to get their flu vaccine. So the objectives of today's talk, you can read them here. We're looking at vaccines and why they're important. Go through some principles of vaccines. What are they? Some are live attenuated, some are killed, some are toxoid or based on a component of the pathogen. Recombinant means that the protein is built from DNA in vitro. We'll go through some diseases that are vaccine preventable. We'll talk about vaccine risks and how we monitor for side effects of vaccines, and we'll talk about anti-vaccine movement. So this, as well as the next slide, talk about the impact that vaccines have had, and they're said to be one of the most important interventions of medicine in human history. So this table compares a number of infectious diseases. Here you see some examples: diphtheria, measles, mumps, and so on. The annual morbidity in the 20th century, measured in the hundreds of thousands or tens of thousands in many cases. And then in 2007, you can see the reduction is on the order of nearly 99%, 100%, 95%. So vaccines have had a major impact on some of these devastating illnesses that used to maim and kill. Similarly, this paper from 2013 compares the estimated cases of a number of infectious diseases that are vaccine preventable, and the number of deaths that occurred in 2002, again showing the dramatic reduction in numbers due to this impressive public health intervention. So this slide shows a timeline of vaccine development, and I'll just tell you the story a little bit here about Edward Jenner, who was one of the pioneers of vaccination. And so the story starts in the 18th century, in the 1700s. And at that time, smallpox was a scourge. It killed a lot of people. It's a disease that can disfigure as well as kill. So beautiful women of the court worried about smallpox scars on their face. And in the time of the Ottoman Empire in Turkey, there was this habit of called variolation, where they take someone who had smallpox lesions, use a lancet to inoculate the fluid from one of the lesions into a healthy person, and actually introduce smallpox into a healthy person. And they do it on the arm or the leg so that the pox, wouldn't be on the face, and it was to protect lovely women of the Ottoman harems from being disfigured by this infectious disease. So that was called variolation, because the disease smallpox is called variola. And Jenner's contribution was that he discovered that cowpox provided cross-protective immunity to smallpox. So the observation was that dairymaid who came in contact with a lot of cows sometimes developed cowpox on their hands, but were relatively protected from smallpox, which is both are similar viruses. So in his historical experiment, Jenner in 1796 took some fluid from the lesions of a dairymaid, inoculated them into a healthy 8-year-old boy. It produced in him some mild symptoms. Subsequently, when he was challenged with smallpox, he was fine. So Jenner observed or hypothesized that smallpox conferred, rather the cowpox inoculation protected the boy from smallpox. And so that was the beginning of a long history of vaccination. Cowpox is called vaccinia, from the Latin word for cow, vacca, And so that's where the word vaccination comes from Jenner's experiment where he took cowpox to protect a boy against smallpox. And so vaccination subsequently spread throughout Europe and ended up protecting a whole bunch of people, saving millions of lives from smallpox. And the story has a nice conclusion because smallpox is the only disease, the only infectious disease that's ever been eradicated from the human population through vaccination. And so after a WHO coordinated worldwide eradication campaign, smallpox was declared gone from the world in the 1970s, and it now only exists in laboratories in 2 locations in the world. So natural spread of smallpox has completely been arrested thanks to the efforts of vaccination. Again, another example of how this um, impressive public health intervention has even resulted in eradication of one disease from mankind, hopefully forever. So I won't go through the remainder of this timeline, but you can see that there's been a number of vaccine developments throughout the 20th century and on into the 21st century. And we'll talk about some of these specifically. Some of the newer ones include human papillomavirus and rotavirus vaccine, which we'll talk about. So just to clarify a point of principle, there's active vaccination and there's passive vaccination. So passive vaccination refers to transfer of immune globulin, preformed immune globulin from someone who's already immune to the disease from one host into the other. And so this just protects you for the life of the antibody, which may be weeks to months. But the host themselves, the recipient of the passive vaccine, doesn't have any memory and therefore can't mount this so-called anamnestic response if they're subsequently challenged. So they're protected for the life of the antibody but not beyond. Then active vaccination, in contrast, means that you've stimulated the host's immune system using an antigen. And so this produces a memory response or an anamnestic response, which mimics natural infection but doesn't produce disease. So just by way of vocabulary, the immunogen is the part of the vaccine which stimulates an immune response. And that immune response might be antibody mediated, which we call humoral immunity, or cell mediated through T cells. And the immunogen, the part of the pathogen that stimulates that immune response, may be a live attenuated pathogen, an inactivated or killed pathogen, or a subunit of the pathogen, meaning the bacteria or the virus or the parasite. So here are some examples of live attenuated vaccines that we use currently. Measles, mumps, and rubella are given as a vaccine to children. Varicella, which is the chicken pox, that's a live viral vaccine. In many areas of the world, oral polio vaccine is given as a live virus, and here in Canada we give an injectable polio vaccine, which is not live. Bacillus calmette-guerin is a tuberculosis vaccine, which is again given in many areas of the world to children at birth to protect them from disseminated miliary or tuberculous meningitis. We don't use it so much in Canada, except in some areas with high TB prevalence. The other example is a traveler's vaccine called yellow fever, which is also a live viral vaccine. So these tend to produce an excellent long-lasting immune response because they're really mimicking natural infection. The virus actually replicates in the host, and the host eradicates the attenuated live virus and thereby generates a lasting anamnestic response. There is some risk, particularly in those who are immunocompromised, and so a rule of thumb is no live viral vaccines to people who are immune compromised. That means cancer patients on chemotherapy, patients with advanced AIDS, patients who have had solid organ or stem cell transplantation, or even pregnant women because of the risk of the live virus to the fetus. Often these live viruses, because they represent a biological organism, require careful conditions to store them and transport them, and so that's what we'll refer to as a cold chain. They have to be maintained in a specific temperature range, which makes challenges for delivering these vaccines to remote areas or very hot areas like as you might find in Africa. So those were examples of live vaccines. Now, what about inactivated vaccines? This is the whole bug, the whole pathogen that's just been killed. So examples are the injectable polio vaccine, which we give to children here in Canada, and it's an injection of the polio which has been killed. And another example was the former pertussis vaccine, which was a whole cell. The pertussis is a bacteria, and the whole cell vaccine was just the dead bacteria that generated an immune response. So here the organism is not going to reproduce or replicate in the host, but it still has quite a complex repertoire of antigens or immunogens that will stimulate a host response. So here we're talking about a little bit weaker immune response than the live vaccine, so sometimes multiple doses might be required. But you're still talking about a host response to the whole pathogen, so that might be more robust than if you're just looking at host response to a single component of the pathogen. Now that also comes with some toxicity. Of course, the host response to some of these bacterial components will generate fever, will generate an immune response which might have some toxicity to the host. So next, let's talk about vaccines that are based on only a subunit of the pathogen. That's only a part of it. So examples here, there are many. We can talk about the pneumococcal vaccine. That's the vaccine against Streptococcus pneumoniae, and that is based on components of the capsule of the bacteria. Another example is tetanus, which we vaccinate for. We use the toxin, the tetanospasmin toxin, which has been inactivated to produce an immune response against that particular protein which mediates disease. Another example is the diphtheria toxin. That's the component of the diphtheria. So for those examples, we're talking about only a specific component of the organism, the bacteria or the virus, and it may be synthesized from scratch in vitro using recombinant technology, where they take the DNA and they make the protein from scratch. It may be a protein, it may be a polysaccharide, which is a sugar, or it may be some conjugate. The pneumococcal vaccine was an example of a polysaccharide antigen on the surface of the bacteria, which is conjugated or linked, covalently linked to a protein, which helps stimulate the immune response. These have a good safety profile because you're not giving the patient the whole bacteria. You're only giving a component, so perhaps a more controlled, more refined sort of pharmacologic procedure. But they might be less immunogenic than the live vaccines, such as measles, mumps, or rubella, which replicate within the host and really mimic the natural disease. Many of these vaccines are so-called multivalent, which means they have multiple subunits, or they have subunits from multiple strains. So the pneumococcal vaccine, again, as an example, has 7 or 10 or 13 different strains of pneumococcus, and the polysaccharide from all those strains is conjugated to a protein, and then that's given as a single vaccine, but you're getting protection to multiple different strains, which gives it the name multivalent. Further word on conjugate vaccines, which I've mentioned. Some bacterial components, like the polysaccharide or the sugars on the cell surface, may be less immunogenic, may produce less of an immune response in the host than a protein. So a strategy is to link the polysaccharide to a protein, such as the diphtheria toxin or any other protein that stimulates an immune response. And here again, we're talking about the examples that among the vaccines that we give routinely to children in Canada: Streptococcus pneumoniae or pneumococcus, Haemophilus influenza type B. In both of those examples, we use the polysaccharide from the bacterial coat, link it to a protein, and that's the vaccine that we inoculate intramuscularly. So these polysaccharide antigens, as I mentioned, might produce less of a host response, so they tend to be less effective in the younger age group, less than 2 years. But of course, this is the age group you really want to target because the younger children are the ones that are more susceptible. They're the ones that carry the highest burden of these infectious diseases. So the strategy of linking the polysaccharide to the protein allows us to protect the young children. These so-called conjugate vaccines produce a longer lasting immunity, which is T cell mediated. The T cells are a particular subset of lymphocytes in the immune system that are kind of like the generals of the army that can direct an immune response and can direct a memory response. So conjugate vaccines produce a T cell dependent response. And the T cells are what we're talking about here is the T cells are directing the B cells to produce antibody, and that's the so-called humoral response. But because it goes through the general of the army, there's a memory that's produced. Furthermore, it's been shown that these conjugate vaccines actually prevent colonization. So Streptococcus pneumonia, Haemophilus influenza can colonize or live on the surface of the upper respiratory tract, like in your throat and sinuses and so on. And so these vaccines actually lead to eradication of carriage of some of these bacteria from the oropharynx. So when some people call this, immunization is stronger than natural immunity because naturally our host response isn't strong enough to eradicate these from the surface of the mucosa, whereas immunization actually causes eradication of these organisms from the surface. And that comes with pluses, but some concerns that if you're changing the flora or the types of organisms that live on your mouth, could they then be replaced with other um, virulent organisms, bad bugs that are then taking their place? So studies to determine the efficacy of a vaccine or how well it works generally have several steps. So the first step is to see if the antibody produces a measurable, to see if the vaccine produces a measurable antibody response in the host. So you inoculate the patient and you measure their antibody levels over time and see if you get a certain threshold which is felt to be protective against the infection. Then, of course, you need to trial that in large, expensive, randomized, double-blind, prospective clinical trials to see if, in fact, the vaccine is protecting people from real disease. So when we talk about efficacy, we're talking about the way the virus works under well-controlled conditions. Effectiveness refers to its real life, how well it works in real life. So that would also include factors like patients who might not complete the series, patients who might get a batch of the vaccine that's not been kept under extremely controlled conditions and might not be as great as a vaccine that's used in a trial. But also the other point is this idea of herd immunity, where in fact vaccines used in a population may have a larger impact than you'd predict based on their efficacy in one individual. So if you start to protect more and more people, you get this so-called herd immunity effect where transmission is actually blocked and the disease can't spread as easily through populations. And so the effectiveness of a vaccine, which includes herd immunity, may actually be higher than you'd predict based on its efficacy in individual patients. So in Canada, there is a system across the country for monitoring vaccine effectiveness called IMPACT, Immunization Monitoring Program Active. And it looks at all the vaccine preventable illnesses and documents the number of hospitalizations due to, for example, influenza or measles or streptococcus pneumonia. And so it's kind of counting the cases of vaccine preventable illness as a metric of how well our vaccine programs are working. The impact program also looks at vaccine side effects, and there's another system in place to look at side effects of vaccine called the Canadian Adverse Event Following Immunization Surveillance System, CAEFISS. In the United States, it's called VAERS, Vaccine Adverse Event Reporting System, and clinicians or even non-clinicians, individuals in the population can report to the VAERS system online. These systems are both passive, meaning that you just wait for cases to come in and you record them as they come in, as well as active case finding. So there's nurses stationed at several of the hospitals across Canada monitoring the pediatric wards for cases of these vaccine preventable illnesses. So a little bit more on the impact program. It's funded by the Public Health Agency of Canada, and the Canadian Pediatric Society is the body that administers it. It's hospital based, so of course we're talking about only a chunk of the pie. There's a lot of vaccine preventable illness out there in the community that never reaches the hospital, and what they're looking for is vaccine adverse events or vaccine preventable diseases. So they're counting, as I said, counting cases of influenza, counting cases of measles as a metric of the vaccine effectiveness, and counting cases, for example, of side effects related to the vaccines in order to monitor vaccine side effects. So yeah, nurses are stationed in several of the Canadian pediatric centers, and they monitor both passively and actively for effectiveness and adverse events related to the vaccine. It's thought that this program covers at least 90% of all the pediatric admissions in the country. So here's just a map showing some of the areas, and the stars here just illustrate all the sites across Canada where Impact is doing its surveillance. So for this part of the lecture, you need to know about the types of vaccines, the types of immunizations that we routinely give to children in Alberta. Describe the vaccine preventable diseases, so the ones we're inoculating against, and then identify the type of vaccine that's used to prevent each disease, so whether it's live, killed, component. So here's the schedule. Pentacell is 5 different vaccines all rolled into one. They are diphtheria, polio, tetanus, Haemophilus influenza type B, and inactivated polio vaccine. And those are given to babies at 2, 4, and 6 months of age, and then again at 18 months of age in a booster dose. The next one is the pneumococcal conjugate vaccine. It's given at 2 months of age, 4 months of age, and then 12 months of age. Simultaneously, the meningococcal conjugate vaccine, or against meningitis, Neisseria meningitidis, is given at 2, 4, and 12 months of age. Measles, mumps, rubella, and combined with varicella, given at 12 months of age, and this is a live virus vaccine. A booster is given at 4 years of age for these 4 diseases that you see in Pentacell. The only one that's missing there is not Haemophilus influenza type B. So you see again diphtheria, pertussis, tetanus, and inactivated polio vaccine. That's given as a booster at 4 years of age. Measles, mumps, and rubella, second dose, 4 years of age, again live viral vaccine. Hepatitis B is given in school in grade 5, and human papillomavirus. This is given currently to girls only, but the Alberta Ministry of Health has just recently announced that they will be giving it to boys as well. Human papillomavirus, as we'll discuss later, prevents both the quadrivalent human papillomavirus that we're giving prevents both genital warts as well as cervical cancer. Then Adacel is a combination of three different vaccines given uh, in grade 9. It protects against three of those same components that we saw before: diphtheria, tetanus, and pertussis. Okay, so this you can find on the web at on the Alberta Health Services website, and it gives you the information for the routine vaccine schedule for children. This is um, information that you should know. So here's just the the legend. I've explained what all those letters mean, but if you want to go back to cross-reference, here is the list. So let's start now with diphtheria. We're going to go through each of these diseases so you know a little bit about what the disease looks like and what we're trying to prevent here. So diphtheria is caused by a bacteria. The bacteria is called Corynebacterium diphtheriae. For those of you who study microbiology, it's a gram-positive organism. And it produces a toxin. And what that toxin does is it forms a so-called pseudomembrane, a thick membrane at the back of the throat. The toxin can also produce a number of other body-wide or systemic symptoms and signs. It can cause myocarditis, so that affects your heart. It can affect your nerves. And the pseudomembrane at the back of the throat can sometimes block off your airway, cause respiratory obstruction. So it has a very high mortality, this disease, highest in the young children as well as the elderly. So that's the disease we're trying to prevent with the diphtheria vaccine. And here's just a picture illustrating that pseudomembrane at the back of the throat. You can imagine how that might cause airway obstruction. If you block off your airway, you are dead. So here's the epidemiology. Back in 1924, about 9,000 cases in Canada. One of the most common causes of death. The vaccine program introduced in the 1950s, and now we're down to only 1 or 2 cases a year. So this is more than 99% of the cases have been prevented. An interesting story arose with the breakup of the USSR, the former Soviet Union. When the public health program broke down because of the political changes that were occurring, there were outbreaks of diphtheria that started occurring again. So you see that how when the control program breaks down, the natural diseases come back. That's one classic example from the 1990s. So this vaccine is one of the component vaccines or subunit vaccines. It's a protein. It's the diphtheria toxin, the one that produces all those nasty disease signs and symptoms. And the toxin is modified. Its structure is changed so that it's no longer called a toxin, but toxoid. And so you inoculate the toxoid and the body can recognize it, but the toxoid does not produce all the disease symptoms. So because the body can recognize it, it can produce a memory response so that the next time you see the diphtheria bacteria's toxin, the Corynebacterium diphtheria's toxin, you can mount an effective immune response and neutralize it. So naturally, because the immune response will be directed against the toxin, you can still get colonization. So this bug, this Corynebacterium, can still live in your throat, can still live on your skin, but the toxin itself, your body will be protected against it. And this, if you think about it, can explain why you get reemergence of the disease if you stop vaccinating, because we're not eradicating carriage, we're not eradicating colonization with this vaccine. We're just protecting against the disease effects by targeting the toxin itself. As you saw in the series, the diphtheria vaccine is given at 2, 4, 6 months, and then 18 months, and then again at 4 years. So that's 5 doses in childhood. And then you need a dose every 10 years to maintain immunity. If you don't give those booster doses, the immunity to diphtheria does tend to wane. So recall that, the diphtheria toxoid, that's the vaccine introduced in 1926, and you're seeing the dramatic drop in cases here. This is the dramatic rise in cases in the USSR, in the former Soviet Union, when the vaccine program broke down. And so you see reemergence of the natural infection. Okay, we're moving from diphtheria now onto Haemophilus influenza type B. So this is another bacteria. For those microbiologists, it's a gram-negative respiratory bacterium. Um, and this used to cause a lot of disease in children under 5. Not so long ago, we're talking kind of maybe 20 years ago. This was a major cause of meningitis as well as sepsis. That means bloodstream infection among young children. So the highest rates were in children under 5, probably the peak in the 6 to 12 month olds. So, like I say, it used to be a common cause of meningitis. Now Streptococcus pneumonia is probably our most common cause. But back in the day, before immunization with Hib, it outstripped pneumococcus by about 6 times. So not only does it cause meningitis, but also bloodstream infections, epiglottitis, which is swelling of the epiglottis at the back of your throat, cellulitis, which is like a deep infection under your skin of the subcutaneous fat, pneumonia, and joint infection. I'll quickly explain what is meant by the B here. So Haemophilus influenza type B. There are several types that you can classify based on their capsular antigen. That's the antigen that's displayed on their capsule. There's A, B, C, letters up to G and beyond. So type B was the most virulent one. That means the one that produced the most disease. And so the vaccine was built to target that type. So it's targeting the polysaccharide, the sugar antigen on the surface of the bacteria, which is type B. So of course that vaccine won't protect you against type A or type C. However, those ones rarely cause disease. This B antigen seems to be necessary, seems to be a virulence factor of the bacteria, and that's the one that's targeted in the vaccine. Here is a global picture of Haemophilus influenza type B mortality rates in the world. And you can see that with vaccine programs, the rates in North America and Europe are quite low, less than 10 per 100,000 children. Now, in areas where there is no Haemophilus influenza type B vaccine program, like in sub-Saharan Africa, you can see that the rates of disease are higher. Here again is a global perspective. This is from a Lancet publication in 2009. The size of the circle indicates the number of cases. So large countries with large populations like India and China will tend to have a lot of cases just because they have such a large population. But here along the x-axis, we're seeing a rate. The denominator here is divided by the population so that you're getting a standardized, normalized rate per 100,000 population. And so, in fact, India and China tend to have lower rates than, say, countries like Angola, Niger in Africa, or Afghanistan in Asia. But because of their large populations, they contribute a large number of cases. Bit about the Haemophilus influenza type B epidemiology. There are about more than 2,000 cases annually in Canada before 1988, and the incidence has decreased by more than 99% over the last 14 years. So IMPACT, which was the surveillance program we talked about, has documented only 4 cases in 2000, and in these cases, some of them didn't get the full vaccine series. So they weren't fully immunized, which explains why they were susceptible to the disease. So once in a Okay, so what type of vaccine is this? It's a polysaccharide protein conjugate. So remember we were talking about those conjugate vaccines where the sugar is linked covalently, it's bound to another protein, and that has the benefit of making it more immunogenic. It makes the body respond to it more. So instead of so this was necessary because we're using this in young infants. So that's the target group where the disease burden is highest. So we need to use this polysaccharide conjugate vaccine in order to target that group. And it stimulates their T cells, so it produces memory. And as we mentioned before, it's combined in that pentacell, those 5 different components include Haemophilus influenza type B as well as the acellular pertussis, diphtheria, tetanus, and inactivated polio. So recall that the schedule is 2, 4, 6, and 18 months of age. You might recall that they give Quadricel, the one without Hib, at 4 years of age. And again, recall that's because the burden of illness here, we're really targeting the under 5s. So although it's necessary to revaccinate for, the pertussis, diphtheria, tetanus, inactivated polio at age 4, not so important to revaccinate for Hib because it's a disease of young children. So look globally, if we look at the Gambia, here's the impact of the Haemophilus influenza type B with the introduction of the national immunization program. You can see the population normalized rates just going down over time. And as I mentioned, this vaccine, better than nature, if you will, better than natural immunity, eradicates carriage from the nasopharynx. And so, what happens when you wipe out the type B from the nose and throat? Do you get replacement with other types? Well, sure enough, you do. You can see type A arising from time to time. Invasive infections caused by non-type B Haemophilus influenza, documented by that impact surveillance. So here's some cases over time of both type B cases in the light purple color and non-type B cases. Those will be the A's and the C's in the pink fuchsia color, and they do appear to be rising over time. The point, though, should be made that the number of diseases that are prevented by the vaccine far outweigh this relatively less important rise in non-type B cases. So the burden of illness overall has vastly reduced, even though you may say that there is a slight increase in non-type B Haemophilus influenza over this time period. Okay, so the next one we're going to talk about is tetanus. It was also part of the Pentacell and the Quadricell vaccine. And you also need a booster for tetanus every 10 years. So it's part of Adacel, and thereafter you're supposed to get your tetanus booster every 10 years. I predict that many people in the audience have not had their 25 and or their 35-year-old booster for tetanus. Nonetheless, that's part of the routine immunizations. So here is the story. This is lockjaw. It's caused by a bacterium called Clostridium tetani. And I'm just showing you a picture here of a patient from Uganda, and she stepped on a nail, or a sharp object at least. So next is a video of this child, and watch carefully for the spasm that she'll get when we stimulate her. So here we are in Uganda, and a hospital in Jinja, Uganda. And this is a patient comes in. There's the spasm. And she's jerking a little bit. So otherwise she has an altered level of consciousness. She's very sick and is at risk even of dying of this disease, but the neurologic feature is that spasm that you saw there. So these are pictures I've spent the past 2 years in Uganda just showing you some pictures from the hospital there. So that was her foot, and that's the spasm of tetanus. The spasm is caused by a toxin produced by the bacteria, and the vaccine is like the diphtheria one. The vaccine is against the tetanus toxoid. So you're protected against the toxin, but not against the bacteria per se. This bacteria is a spore former. It likes to live in soil, and so even if you immunize the population, the bacteria remains alive and well in the soil. So anytime you get a dirty wound, you're at risk of tetanus if you're not immune. That's why if you ever have, say, an open injury in the barnyard, you should make sure your tetanus vaccine is up to date. If it's not, you might have to come into emergency so that they can give you vaccine and or a passive immunization with tetanus immune globulin to protect you from this kind of disease. In Canada, it's relatively rare. One other interesting thing is neonatal tetanus. So if the mother doesn't have antibody against tetanus, the baby can get tetanus, and this is often a fatal condition. So this is another baby that we saw in Uganda, and you can see the posture. The head is arched, the back is stiff, and this is called opisthotonus. It's a stiffening of the muscles, a rigidity related to that tetanospasmin, the toxin produced by the Clostridium tetani bacteria. So next we'll go on to talk about measles, mumps, and rubella, and this is a live virus vaccine in all three cases. So for measles, we're hopefully going to talk about this in our classroom discussion. So if you could pay attention here to this disease and try to remember it for our classroom discussion. We'll go over measles in some detail, and I'll talk about a measles outbreak that occurred in Uganda while I was there. So measles disease, what does the disease itself look like? Well, it's characterized by fever, and then there are three C's: cough, coryza, and conjunctivitis. Coryza means runny nose, cold-like symptoms. Conjunctivitis means red eyes. And the measles rash is very characteristic, and these so-called Koplik spots, Koplik spots are on the inside of the mouth. They're a little bluish mark on the inside of the mouth. They're tough to find as a doctor because they come before the rash appears, and they disappear as the rash is coming on. So by the time the patient presents to the doctor with fever and rash, often the Koplik spots are already gone. Complications of measles include ear infection, pneumonia, some barking cough called croup, diarrheal illness, and the post-measles pneumonia can actually be a killer, and it's right up there on the list of major causes of mortality worldwide. Um, for Other complications include encephalitis, which is infection of the brain, and it can lead to permanent brain damage. Sometimes death occurs, and this is, like I say, in low-income countries, it's actually a fairly high. One thing to note is the link between measles and vitamin A deficiency. So part of the treatment for measles in a country like Uganda is supplementation with vitamin A. An interesting disease caused by measles is subacute sclerosing panencephalitis, and it should so sub it's subacute sclerosing panencephalitis. I've just corrected the spelling there. Devastating disease often occurs 10 or 15 years later after the primary infection. So in typically a teenager presenting with a progressive, um, unremitting, degenerative neurologic disease, which can be devastating. This is the classic rash of measles, bright red, and measles is a highly infectious. It's said to be one of the most contagious of all the infectious diseases, and can be spread by droplet nuclei. Um, it As a result, you need to have a very high level of vaccine coverage in the human population if you want to prevent measles outbreaks. So we're talking levels of 80% or higher. If you have less than that, then there's enough susceptible individuals in the population that this highly infectious virus can still cause outbreaks. Nonetheless, the vaccine is highly effective and causes a sterile, lifelong immunity. What we mean by sterile is you don't get just a little bit of virus or an attenuated mild infection. You get no infection whatsoever. You're fully protected with no virus once you're immune. This measles virus has been in the news recently. In November 2013, this is a CBC News report, just a screenshot from CBC News report in November, talking about a measles outbreak that occurred in southern Alberta. And these are people who were not getting vaccine for religious reasons. So again, like the diphtheria in the former Soviet Union, you can see when vaccine rates start to drop, natural disease returns. And so you can see the characteristic red rash on the back of this child here. Several dozen cases, right? 40 measles cases, no deaths in this outbreak. So in Canada, since the vaccine was introduced, the incidence has dropped a lot. There's still sporadic outbreaks, as shown with it as recently as this year, as 2013 November. And we've mentioned that a high level of herd immunity is required to prevent transmission just because of how highly contagious this virus is. We give 2 doses of the measles vaccine, and that's been in place since 1995. A single dose protects most people, but not everybody. So the second dose is meant to catch those people who weren't immune after one dose. Occasionally we get clusters of measles that are usually imported from other countries. But because our population vaccine rate is fairly high, these outbreaks tend to die off. They don't spread like wildfire through the population because most people are immune. What type of vaccine is the measles vaccine? It's a live viral vaccine, so it does replicate in the host. So beware in immunocompromised patients. They shouldn't be getting measles vaccine if they're severely immunocompromised. And it's given in combination with the mumps and rubella, so MMR, measles, mumps, and rubella. And it's given at 12 months of age, and it's given again as a booster around 4 years of age. So we're talking 95% effective if it's given after a year of age. And with the second dose, we get up to 100% effective. So 2 doses are given in Canada. That's not true everywhere in the world. Some places have low coverage rates even with 1 dose, like Uganda. It's around 70 to 80% coverage with a single dose. So they need to work on getting their population coverage with 1 dose up beyond 80% before they can consider introducing a second dose into the public health program. If you give the vaccine below a year of age, the efficacy is reduced because maternal antibody, which is transferred from transplacentally from the mom to the baby, interferes with that live virus. So the mom's antibody actually mops it up before the baby has time to mount an immune response and develop memory. This is relevant to developing countries because often in places like Uganda or other sub-Saharan African countries where there's a lot of measles going around, you want to try to protect the babies as much as possible. So they push the vaccine down to 9 months of age. So in Uganda, the program is measles vaccine at 9 months of age instead of 12 months. So there, what you're sacrificing is a little bit of effectiveness because the maternal antibody will be present, but the benefit is that you're protecting children at a younger age. So that's the kind of balance of factors that it is just an illustration of a balance of factors that has to be taken into account when designing a public health program for measles vaccine. Next, talk about the adverse events of the measles vaccine. Because it's a live virus that's actually replicating in your body, between a week to 2 weeks after the vaccine, you can get fever and rash, mimicking the natural infection, and you can get a low platelet count, thrombocytopenia. And that's, again, similar to what you get with the natural infection. This is not as severe as wild-type measles, though. So here's the epidemiology in Canada. The live vaccine licensed in 1963. And in the 60s, there weren't so many reportable cases. Anyway, you can see the point here is that the cases are fairly high before the vaccine program's introduced, and afterwards we see relatively few measles cases, although there are sporadic outbreaks. So in the world, there's still a lot of measles around. 2.6 million cases in 1980, down to about 140,000 cases in 2010. So vaccine is being used worldwide. Measles cases are decreasing, but there are still sporadic outbreaks. Highly contagious infection need very high population levels to prevent outbreaks. Here are measles cases according to WHO region. So for example, the light gray bars show Africa, and tends to be fairly high number of reported measles cases. And countries like the Americas, the middle gray bars, tend to report very few measles cases. On the y-axis on the right-hand side here, we can see that the percentage of countries with a low incidence of measles is rising. So that means that more and more countries are improving their measles vaccine programs and reducing the number of measles cases. So there's a slight but significant increase in the low measles prevalence countries over time. Again, globally, you can see the estimated cases of measles that are prevented by a vaccine, illustrated by these pink bars. So in the blue line here is the real measured measles cases as reported or as estimated in this Lancet 2012 population. And here's what it would be if there wasn't any vaccine. So the pink bars represent the difference, the number of cases averted by vaccination. Now, because of a scare about the adverse events related to measles vaccine, immunization rates in the UK have dropped in the past decade, and sure enough, measles returns. So loss of confidence in the MMR vaccine has led to low vaccine rates and increase in outbreaks of the natural infection. And this is all related to a scare about autism, that the MMR vaccine was causing autism. And you can perhaps understand the concern of a parent whose child is not speaking well, doesn't develop language normally, doesn't develop normal social interactions. Those kind of milestones are expected around the time, around a year of age to 2 years of age. That's when language is developing rapidly. And if it doesn't happen, you're looking for a reason, and sure enough, the child got vaccine, MMR vaccine, at 12 months of age. So it just so happens that those two, when a child is diagnosed with autism, and the timing of the MMR vaccine happened to coincide in time, and so it's tempting to make an association between the two, but of course that association isn't causal. So the controversy comes with this 1998 article published in a very prominent journal, The Lancet, by a guy by the name of Andrew Wakefield, who published a case series about a hypothesized link between the measles, mumps, rubella vaccine and subsequent development of autism. But this has been thoroughly discredited by the scientific community, and many subsequent studies have failed to determine any link at all between MMR vaccine and subsequent development of autism. So this slide here just goes through in 2004, the authors are retracting their participation in this article, and the UK's regulatory body finds that Wakefield acted dishonestly and irresponsibly in his research, and the Lancet retracts the article. So it's all that to say that the article was flawed, and the consensus in the medical community is that no, there is no link between MMR vaccine and autism. Nonetheless, this idea gets a lot of traction in the public. So the next one is mumps. It's also a live viral vaccine, part of the MMR. So mumps disease causes a swelling of the salivary glands. So you see puffy chipmunk cheeks. Many of the infections are asymptomatic, but it can cause some complications like orchitis. That's inflammation of the testes. Usually, males. This occurs in teenage males, and it doesn't usually cause sterility as a result. Mumps also causes joint pain, joint infections, can affect the heart, can cause hearing impairment. So it's a cause of morbidity that's disease, but it's an uncommon cause of death. Doesn't usually kill. So here's just a picture of the swelling cheeks, the parotitis that you see with mumps. Most of the infection tended to occur in childhood, and death in children was very rare, but could occur occasionally in older patients who got mumps infection. Previously, there were about 237 cases per year, but nowadays it's very rare for this disease to occur. There was an outbreak in eastern Canada several years ago. Again, the vaccine is live attenuated, so beware in immunocompromised patients, beware in pregnant patients, and it's given in as I mentioned already, in combination with measles and rubella and MMR. One dose is 95% effective, and two dose should prevent outbreaks by providing lasting immunity. Um, if you only got one dose of MMR, by the time you reach your teenage years, 10, 15 years later, then you can have waning immunity and be susceptible to mumps. So in eastern Canada, there was a mumps outbreak um, related to waning immunity in patients who had only received one dose of mumps vaccine. So this is the outbreak I was referring to. It occurred in 2007, and you see in light blue Nova Scotia were the highest number of cases. This graph is what's called an epidemic curve, where we see the weeks plotted along the y-axis and the number of cases, sorry, along the x-axis, beg your pardon, and the number of cases along the y-axis. So you can see that the epidemic rises to a peak and then slowly wanes off as the infection dies out. So that's a classic epidemiologic curve. And again, light blue, most cases occurred in Nova Scotia in 2007. These did tend to occur in older teenagers and young adults. And so, yes, the males did get testicular pain um, uh, with the orchitis that you see with mumps. So rubella is the third in that MMR. Tends to produce a mild rash, lymphadenopathy, which is swollen nodes, swollen glands, and fever. Many people don't have any signs or symptoms at all with this infection. But the thing we're worried about with rubella is this congenital syndrome. So if the pregnant mother gets it, the baby can get this congenital rubella. With the rash, their liver and spleen can be large, their bone marrow can be affected, their heart, eyes can be infected, and this produces a damaging syndrome to the baby. So it's a very high risk if it occurs in the first trimester. And so yes, just to recap the congenital rubella syndrome, the babies are born small. They might have a rash on their skin. They may have a large liver and spleen, brain damage, deafness, heart problems, and problems with the eyes. So before 1983, they were immunizing girls because the thought was, well, if it's only we're really worried about the congenital rubella syndrome. Therefore, if we protect the women, that should be enough. But because half the population remains unimmunized, you can still get large outbreaks of the virus, and so the occasional unprotected pregnant woman would still be at risk. So then they switched to male and female vaccination strategy. Occasionally, you do get outbreaks of rubella in unimmunized populations, like we saw for measles and mumps. So just to point out here that we're vaccinating the population against rubella not to protect against the relatively mild viral infection, but to protect the pregnant women and their fetuses from congenital rubella. Uh, Mentioning again that it's in combination with the measles, mumps, and rubella vaccine and MMR. And adverse events, like we saw for measles, there can be fever and swollen lymph nodes 1 to 3 weeks after the vaccine, because remember, this is a live virus vaccine. It's replicating in the body, so uh, the host does mount a response just like it does in natural infection with fever and swollen lymph nodes. And it can produce, like the natural infection, some joint pain. But these are usually mild symptoms, and they're not as bad as the wild-type rubella disease. So, going on now to another infection, pertussis, which is whooping cough. This is a bacterial infection caused by a bacteria called Bordetella pertussis. Now, what we're worried about with pertussis are high morbidity and even mortality in the young infants. So whereas teenagers and adults tend to get this prolonged cough with pertussis, it's sometimes called the 100-day cough, babies can actually stop breathing. They get apnea and can even die of pertussis. So we want to vaccinate the population again to protect the babies from very serious disease. There's different generations or of this vaccine, where an old one was a whole cell killed vaccine with all kinds of antigens that the bacteria has and produced a lot of side effects, prolonged crying and fever and febrile seizures, which means seizures that are associated with fever. So it was more reactogenic, caused a lot of side effects. And so they've switched now to an acellular vaccine with different components of the pertussis bacteria, but it's not the whole cell vaccine anymore that we give. So this has fewer nuisance side effects, but then again, if you're not giving the whole bacteria, perhaps there are fewer antigens, and perhaps it may be less effective. So here's the data on pertussis cases from 1924 to 2004, decreasing with the vaccine program in the 40s. Now that's here. Then the acellular vaccine replaces the whole cell vaccine in the late 1990s. So within the past 25 years, if we break the rate of pertussis down by age group, you can see that in the young adults, teenagers and young adults, the 15 to 19-year-olds, the pertussis rates are actually significant. That's related to waning immunity from their last booster dose, but their last shot at 4 years of age. So again, if you look back to that original vaccine schedule, there's an Adacel recommended for boost, which contains the acellular pertussis to boost the immunity of these young adults to pertussis. Next disease, we're talking about now varicella, which is chickenpox. Varicella is also the cause of shingles. So the same virus can reactivate in your body often in old age and produce shingles, whereas in the primary infection, the first time you see it, it produces chickenpox, usually in children. So the natural disease caused by varicella is an itchy rash with small blisters and can be a mild fever. Um, the some complications that you can get a bacterial superinfection of the skin. So often group A streptococcus, which is can in extreme cases cause the so-called flesh-eating disease, and the risk of that is said to be 50-fold higher if you have varicella. So the risk of bacterial superinfection with sometimes dangerous bacteria is increased a lot if you have varicella infection. It can cause low platelet count, can cause joint pain, liver inflammation, cerebellum, which is a part of your brain that's responsible for balance. It can affect that and cause a funny gait called ataxia. It can infect the brain, encephalitis, and can affect the lungs, causing pneumonia. So yes, invasive group A strep disease, necrotizing fasciitis, which is the flesh-eating disease, is increased 50-fold when you have varicella. Herpes zoster, which is also called shingles, is caused by the same virus. So this is a very common infection, even in Canada and in other temperate countries. It tends to be lower in tropical countries. So they say that 90% of children by age 12 catch varicella. Here you see the typical lesions. These ones look like they're kind of scarring over, but you'll see lesions in different stages of evolution. So some are blisters, some are scarring. This girl, the pen line here is delineating a large area of redness where she probably has bacterial superinfection. So the bacteria got in through one of those spots in the skin and are causing pretty bad swelling here in a critical area around her neck. So the vaccine itself is a live attenuated virus, just like the measles, mumps, rubella. It's called Varivax. It's given in combination with MMR at 12 months of age in Alberta. That started 2001. And since August, it's given as the combination combination with MMR. So just to clarify that varicella was given separately at 12 months of age in 1991, and since August 2010, they're giving it in combination with MMR with this product, MMRV. It's a very efficacious vaccine, Sometimes you can see breakthrough chickenpox cases in vaccinated children, but they tend to be mild and there are fewer spots than in the wild type disease. Their adverse events are minimal with mild, like a little bit of soreness at the injection site, maybe a mild rash. Again, much less severe than the natural disease. Also to point out that there is a shingles vaccine. It's against the same virus, but it's given in it's a much higher titer because it has to stimulate immunity in older patients who may have a senescent immunity, so kind of a waning immunity in old age. Here we're looking at Canadian data, trends over time, and in the 1 to 4 year age group, you can see declining rates of hospitalization due to varicella after introduction of the vaccine in 2001. And here's again the impact data, the surveillance program data on 9 varicella-related deaths from 2000 to 2007. And you can read this, but you'll see that many of the cases were not vaccinated. One thing about varicella is that it tends to produce mild fever and rash in children with an itchy rash that goes away eventually. But in adults, it can be much more severe disease, higher morbidity. So what happens if you vaccinate children and then you have waning immunity? Does that mean you're going to shift the curve towards more adult disease and more severe disease? So that's one of the questions that arises with varicella vaccine. Um, and the other question is whether the varicella vaccine might have an effect on shingles disease in older adults. And this could be either by reducing the burden of illness in children so that they're less likely to spread it to adults, or eventually perhaps there is some residual immunity from childhood that might protect adults from shingles. Again, there is a specific shingles vaccine with high titer virus that's designed to protect older adults from shingles, which is reactivation of the varicella virus from latent sites of infection in the body. Okay, we're moving on to another disease now called meningococcus. This is caused by a bacteria called Neisseria meningitidis. And the diseases it causes are either a sepsis, which is like a bloodstream infection, meningococcemia, or meningitis, infection of the brain. And this disease can be very rapidly progressive. Fever, chills, prostration, rash, a so-called purpuric rash, and the patient can progress very quickly from well to death. So it's important for doctors to recognize this and to be prepared for it. Also helpful to vaccinate against it. This is the so-called purpuric rash of meningococcus. You can see they're little spots, and if you press on them, they don't blanch. That means they remain red even when you push on them. Whereas something like measles tends to blanch. This child is obviously critically ill with his meningococcemia. So in Canada, the highest incidence occurs in babies, in children under a year of age. There does also occur as a peak in teenagers, and this is probably because this disease, this bacteria, lives in the nasopharynx and can be transmitted by sharing secretion, so kissing. So in that age demographic, we can see increased transmission of Neisseria meningitidis, and outbreaks can occur in things like college dormitories. Well described. The fatality rate is high, so if you catch this disease, it's bad. There are several serotypes. That means the bacteria strains are different, characterized based on their surface antigens. So there's serotypes A, B, C, Y, and W135. The most common ones in North America are the B, the C, and the Y. And Africa has a special meningitis belt where these diseases occur at very high frequency, and that's most commonly A. One thing about the African illness is it can be a travel-related illness, as many Muslim Africans travel to Mecca for the Hajj. There's been outbreaks related to importation of Neisseria meningitidis in the event of that large group gathering, where you can imagine there may be increased contact, human-to-human contact, and perhaps sharing of food, of secretions that can increase transmission of Neisseria meningitis. So the vaccine is actually required if you're going to take a pilgrimage to the Hajj. That was implemented by Saudi Arabia within the past 5-10 years. So here's the meningitis belt in Africa. It tends to occur in the dry season in the Sahel area, just south of the Saharan desert. If you're traveling to these areas, you should get vaccinated with the quadrivalent meningococcal vaccine. So, what is the vaccine? It's a polysaccharide vaccine. There are several types, rather. One type is a polysaccharide vaccine. So it contains um, uh, antigen from several strains, 4 strains: A, C, Y, and W135. So you'll notice that the B the B strain is missing. There are technical difficulties in making a vaccine against B, so that the currently available quadrivalent vaccines cover the other 4 strains, but they don't cover B. So of course, this is a polysaccharide vaccine. So as we've seen before for pneumococcus, it's not very good in children under 2 years of age, and yet this is the highest. This is the age group that carries the highest burden of disease. So what can you do instead is you can make a conjugate vaccine where you link these polysaccharides to a protein and thereby enhance the immunity in young children and make it a T cell dependent response with memory. So now this conjugate vaccine, which is against type C only, so of the 5 types, it's men only against the C serotype of Neisseria meningitidis. That's now part of the routine Alberta schedule at 2, 4, and 12 months of age. Now, there is a quadrivalent conjugate vaccine, so that means the polysaccharide from these 4 strains, ACYW135, is conjugated to a protein. It's called Menactra or Menveo. So far, the National Committee on Immunization for Canada has not recommended introducing this into public programs just because of the epidemiology of the disease. It's not going to give too much more of a bang for your buck over a vaccine for C alone. The serotype B, as I've mentioned, there are technical difficulties in making a vaccine against the B polysaccharide, but it's in the pipeline. So here's the impact surveillance rate per 100,000 of meningococcal disease split up by groups. So B, you can see, is the most common one and the one for which we have no vaccine whatsoever. C, for which we have the conjugate Men-C vaccine that we routinely give in Alberta, rates declining over time with vaccine program. And then there's Y and W135 here. And A is relatively rare in Canada, but as we mentioned, more common in Africa in that meningitis belt. So we're moving on to a different pathogen now. This one's called Streptococcus pneumonia. It's a bacteria. It's a common cause of, again, meningitis, sepsis in young children. So we'll talk about several pneumococcal vaccines and how the vaccination against this bacteria has evolved. But first, a word on the disease. Common cause of pneumonia, but also bacteremia, that's bloodstream infection, and meningitis, that's brain infection. Also causes middle ear infection, sinus infection, joint infections, and right now it's the commonest cause of bacteremia or meningitis in young children. Not only does it affect the young, but it can affect the elderly as well. There's some risk factors for severe pneumococcal disease, including no spleen, immunodeficiency, chronic diseases. So there's still a lot of deaths due to pneumococcal disease, and even in particularly in fact in developing countries where there may be no pneumococcal vaccine program. Here's the age distribution of pneumococcal disease in Canada. You can see it affects the children under 1 year of age and 1 to 2 years of age most commonly. And after that, the incidence goes down. Here's the breakdown of the diseases caused by pneumococcus from Canadian data. Bacteremia, which means bloodstream infection with no apparent source, is causes the lion's share. Then with otitis, media or sinusitis as the source of infection, still bloodstream infection. Bacteremia is this part of the pie. Pneumonia, and about a fifth. Meningitis, and others including cellulitis and septic arthritis, which is joint infection. So, there are so many different serotypes of pneumococcus. How do you make a vaccine that's going to cover the disease when there's so many different strains of bacteria that cause it? The other problem is that, like the Haemophilus influenza type B and the Neisseria meningitidis, these distinctive antigens on the surface are polysaccharides, or they're sugars, so they're not very immunogenic. Here's a graph representing all the different serotypes of pneumococcus and in order of which one causes most invasive disease. So in order of frequency, you can see 14, serotype 6b, serotype 19f are causing most of the disease. And so the strategy has been to target the most common ones. So one of the first uh, one of the vaccines against pneumococcus that we were using was against the top 7. So 14, 6b, 19f, 18c4, 23f, 9v. So those were the serotypes contained in the 7-valent pneumococcal vaccine. A good point to be made here is that the studies that determined the relative frequency of all these serotypes were done in North America. And so the strains that circulate in other parts of the world, like Africa, like Asia, may be quite different. And so the vaccine that you've kind of designed for your North American population may not work quite as well, may not have quite the same coverage in a different area of the world. So this graph repeats that point. If you look at um, the the different pneumococcal vaccines, PCV7 covers the 7 most common serotypes, PCV10 covers the 10 most common serotypes, and PCV13 covers the 13 most common serotypes. So of course, as you go up in the serotype coverage, you're increasing the percent of children that you're protecting, and that's true in all areas of the world. However, where the vaccine is designed, based on the data from North America, that's where it's most effective. If you look at somewhere else like Africa, you can see that the 7 most common serotypes contained in the 7-valent vaccine actually only cover about half of all the invasive pneumococcal serotypes found in Africa. If you go up to the 10-valent and the 13-valent, you're getting better coverage. This is data from California before and after they introduced the pneumococcal vaccine, and you can see that the vaccine efficacy is in the high 90s, depending on the way you analyze the data. So it looks like a good disease for invasive pneumococcus. The other problem that we talked about was that the disease burden in young children means that we have to immunize with a conjugate vaccine. So this was introduced in Alberta in 2002 and is given like the meningococcal type C vaccine on a schedule of 2, 4, and 12 months. Just as we saw for Haemophilus influenza type B, pneumococcus cases are decreasing since introduction of the vaccine. And what this graph is talking about, PCV7, that's the 7-valent pneumococcal conjugate vaccine. So again, the 7 most common serotypes, and the polysaccharide from those serotypes is conjugated to a protein to stimulate better immunity. As I mentioned, there are 2 other vaccines that have since come since PCV7. There's the 10-valent and the 13-valent. The 13-valent vaccine is the one we currently use in Alberta. Pneumococcal vaccination also produces herd immunity and may therefore prevent disease in adults, because the elderly are also they also carry a high burden of pneumococcal disease. The other thing is that drug resistance is a problem in pneumococcus. Doctors struggle with emerging drug resistance and knowing what best antibiotic to use. And because pneumococcus causes ear infections, which are a very common reason to visit your pediatrician, there's a lot of drugs doled out that can create pressure, which allows the emergence of drug-resistant strains of pneumococcus. However, if you vaccinate and you reduce the burden of illness that way, you may also be reducing drug resistance among the invasive pneumococcal strains. So here we're seeing the evidence of some of this fringe benefit when children are vaccinated with the pneumococcal conjugate vaccine, the 7-valent Prevnar, so-called Prevnar vaccine. You can see trends in adults. These are young adults aged 18 to 49 years, decreasing over time. But that also spills over even into the elderly. There tends to be a decreasing trend over time after introduction of the vaccine program. Some of the commonest strains that cause invasive disease are also the ones that tend to be drug resistant. So vaccinating against those also reduces the burden of drug resistance, as we mentioned. So here's an example here where we're seeing the resistance to a class of antibiotics called macrolides, and the incidence of macrolide resistance among invasive pneumococcal isolates is decreasing after introduction of the conjugate vaccine. That was one of the fringe benefits of pneumococcal vaccination. You'll recall the story with Haemophilus influenza type B, where there was concern about serotype replacement. If you eradicate carriage of Haemophilus influenza type B, might there be more cases of A coming along? Same story with pneumococcus. If you reduce the carriage, the nasopharyngeal carriage, and rates of invasive disease caused by the 7 most common serotypes, will the other serotypes move in and replace it? And sure enough, there have been reports of increased rates of non-vaccine serotypes in more recent years. Here's some more data. After introduction of the vaccine, you see a drop in the 7 serotypes that are contained in the vaccine. However, the strains that are not contained in the vaccine seem to be increasing. This is called serotype replacement. Here's similar data from Alberta. We're seeing in the blue line the serotypes contained in the PCV7, or the 7-valent pneumococcal conjugate vaccine, decreasing after introduction of the vaccine program. And in green, we're looking at strains that weren't contained in the 7-valent 7-valent conjugate vaccine, and they may be rising somewhat over this time period. Partly as a result of this concern, Alberta has switched now to a 13-valent vaccine, and the rates of those pneumococcal strains contained in the 13-valent vaccine may now be decreasing. So the additional strains or their serotypes contained in the 13-valent conjugate vaccine are these ones: 1, 3, 5, 6A, 7F, and 19A. And so you get additional coverage with this 13-valent one that you didn't get with the 7-valent one. So that concludes our review of the different pathogens that are vaccine preventable. We're going to talk about some general issues now. The first one, global vaccine coverage. So how many children in the world are getting vaccinated against these diseases? So about 85% of the world's children are getting all 3 doses of the diphtheria, tetanus, pertussis vaccine. Now, in some areas of the world, it won't be 85%. Those low-income countries with weak healthcare infrastructure will have lower rates than that. But that's the overall figure for the world. 75% of the world's children are getting 3 doses of hepatitis B vaccine, and not quite half are getting the Haemophilus influenza type B. Very few of the world's children are getting immunized for both pneumococcus and rotavirus, which are this is a diarrheal pathogen that we'll hopefully get to talk about in the classroom discussion. This graph just shows the increasing immunization rates against those 3 diseases: diphtheria, tetanus, pertussis, on a global scale. The WHO region that's always the lowest in the vaccine coverage rates is Africa, but even in Africa, vaccine rates are increasing. That good news is just tempered by a large burden of children that remain unimmunized. The largest number occurs in highly populous India, but also Nigeria, Democratic Republic of Congo, and so on. future directions, we need to improve the access to some of these vaccines in the lower income countries. So a conjugate vaccine for pneumococcus exists, and there's a high burden of illness globally, but it's just getting that vaccine to those who need it. And it is expensive. There is a financial cost that's difficult for low resource countries to afford. Rotavirus vaccine, another recent one on the market, but again, getting it to the countries with high in low-income countries where the burden of rotavirus illness morbidity is high, that remains a challenge. HPV vaccine is another more recent one, helps prevent cervical cancer, and that would be a great vaccine for developing countries where they don't have a pap smear program, and yet it's expensive, and rolling it out is the issue. Then there's vaccines that people are working on. Malaria, high global burden of illness, but vaccine has been elusive for literally over a century of efforts. Tuberculosis, again, very common disease, needs a vaccine. We need a vaccine for dengue virus, which is a resurgent infection in the tropics, and hepatitis E, HIV. Progress is in different stages against these ones, and hopefully we'll get to talk about the uh, malaria vaccine as an example in our classroom discussion. So getting vaccines to the population is easier said than done. There's a lot of logistical constraints and concerns involved. Um, a few among many issues in terms of in a public health vaccine campaign. There's the physical characteristics of the vaccine. So they need to be available. There has to be a supply chain and no stockouts in hospitals. Quality handling of the vaccines, maintaining that so-called cold chain, administering them in a safe way without reuse of needles, and making sure that programs are in place to dispose of the needles properly. Um, and, but another element is just information for the public, encouraging them to come for vaccination so that they understand the benefits, but also understanding the risks that are probably minimal with respect to the potential benefits, and a system of data collection to monitor adverse events and vaccine efficacy and vaccine preventable illness is helpful in that cycle of information and feedback for any vaccine program. So some of the challenges, cold chain, as we mentioned, particularly for those live virus vaccines, which are a little bit more sensitive or fragile to temperature changes. Imagine that it has to be maintained from the point of virus manufacture through transportation and storage, all the way to delivery at the bedside. And in some countries, like imagine the transportation logistics to a remote African village, perhaps on bumpy roads, and needs to be maintained a cold chain at 30 degrees in the tropical heat. So that those aren't small challenges. Equipment such as refrigerators and transportation personnel, skilled personnel that can administer the vaccine into the muscle without causing harm. Um, those can be challenges in some areas. A number of international groups are involved in global vaccination campaigns, including the Expanded Program on Immunization, EPI, UNICEF, the Global Alliance for Vaccines and Immunization, Gavi, and the Bill and Melinda Gates Foundation. The Gavi Alliance is an example of a public-private partnership, a PPP, which involves a number of key stakeholders, philanthropists, and vaccine industry, policymakers in developing countries, non-governmental and civil society organizations, all with a mandate to promote and encourage global vaccination of the world's children. Here are the four strategic goals of Gavi, and I'll just let you read those. The next topic is an important one related to a reaction against vaccines, particularly in the developed world, much more so than Africa, where the problem is availability and cost of vaccines. In North America and Europe, threats to vaccine programs come from concerns or doubts about their safety. And this anti-vaccine movement has got a lot of traction in among concerned parents. So at its base, this anti-vaccine movement arises because we're giving an intervention to a healthy person. So unlike treating disease, few people object to, an antibiotic for an infection. But in this case, we're giving an infection to a healthy host, a normal child, no disease. And we're doing that to prevent future infection. But if people don't feel the threat, the imminent threat of infection because they've never seen a case of measles or they've never heard of a case of rubella, then it's more difficult to convince them of the value of vaccination. There's also, of course, a balance to be struck between individual benefit and public health or population health, since on the one hand, an individual's right to decide on their child's health interventions needs to be balanced by the public good, herd immunity, and prevention of these diseases, which, as we've seen, in their natural state, can kill and maim. So I'll just let you read this slide, but the medical community agrees that vaccines are efficacious, effective, and that they are safe. Severe side effects are rare. We're talking on the order of 1 in a million. And there's systems such as Impact that are in place to monitor side effects. Impact in the pediatric hospitals and VAERS in the USA, Vaccine Adverse Event Reporting System. As we've seen in several examples, if we stop vaccinating, natural disease returns. So measles, both in Ireland with waning MMR vaccination, we talked about the former USSR where diphtheria made a resurgence after breakdown of vaccination campaigns in that side of the world. We've seen in Alberta, most recently in November, measles outbreaks in communities without measles vaccine. And several more examples can be cited. But clearly the natural diseases remain, and if you don't vaccinate the population, outbreaks can occur. So next question, why should we bother if we've managed to reduce the incidence of these severe diseases? The point is, as we've seen from those outbreaks, that the diseases do continue to circulate globally. There's lots of international travel. If you let the population immunity wane, these diseases can easily be reintroduced. And although the outbreaks are small when most of the population is vaccinated, if you allow vaccine rates to wane, those small outbreaks could become large epidemics. People sometimes worry about vaccines weakening the immune system, quote unquote. No, in fact, they boost the immune system, they stimulate it, they produce memory to a disease that you haven't seen in its natural state, and thereby improve your body's ability to fight subsequent diseases. There's concern that our children get so many vaccines these days, but of course the number of antigens that you get in a vaccine is far more restricted than natural exposure to a whole pathogen. And that's particularly true of those so-called subunit vaccines that we were talking about, where you're presented with a single protein as opposed to the multiplicity of antigens on a native bacterium. Lots of concerns about severe adverse events related to vaccination. We talked about the most famous case, which is MMR and its supposed association with autism. That it has been debunked. There's also others have claimed that MMR is related to inflammatory bowel disease, also not confirmed in large studies and refuted basically in the medical literature. Hepatitis B vaccine cannot be blamed for multiple sclerosis. There's no association there in large epidemiologic studies. The pertussis vaccine, there's no association with brain damage, although some people worry about that. And there's no association with asthma or sudden infant death syndrome. So, just to wrap this all up, vaccine preventable illnesses are an important cause of morbidity and mortality all over the world, but particularly so in the developing world, where disease burden is highest and vaccine rates are the lowest. Vaccination is striking as one of the most important, most useful, and most effective public health measures of all time, and the eradication of smallpox, as we discussed, is a triumph of human technology over disease that was produced through vaccination. Here are some web resources that you can refer to. This Alberta Health will give you the routine immunization schedule for Alberta children. Canadian Pediatric Society has a number of statements on vaccination. The Public Health Agency of Canada. There's a National Advisory Committee on Immunization, NACI, which publishes statements as new vaccines come out to guide public health policy. Um, and there's a number of others, including the Americans, the CDC. Uh, so that concludes this talk on vaccines and their role in public health. And happy to entertain questions during the classroom discussion. We will discuss some additional scenarios, and participation will be encouraged, and your opinions will be solicited during this classroom discussion, which will be more an exercise in creative thinking than facts. So, looking forward to meeting with you all during the classroom discussion.